Right. So, that's the end, 60? Yeah.
Sir, answer is red को सबको लेके.
Where is the red? The whole reds have come? Huh. No, there are 1, 2, 3, 4. It's not any. Yeah. So they won't get the flow of the event if they're not there. Because it should be filled. There is 60 capacity. There are around 20 people.
Anand sir का bench left. Anand sir ले
क्या?
Red bench. You got it. Anand sir. क्या
Basically, 8:30 to 9 o'clock, he was supposed to talk.
Hello. They're all there? How can it be 60? It has to be 60.
Actually, so Bukhara was a black band scheme.
ये level ही every
Wet lab, dry lab.
Wet lab, dry lab वाले ये देना black वाले.
They are all very.
जो भी है.
Well, so good afternoon, everyone, and let's try to make this as interesting as possible. So, my name is Dr. Sanjit, and we sorry on the brochure you see Dr. Sheila written over there, but Dr. Sheila is not in, so I'll be taking this session for you guys. So what we're going to do is we're going to talk of acute hypoxia. All right. Now, there are a lot of objects you can see on the screen: the eye gel, the combi tube, the ambu bag, the nasopharyngeal airway, the styloid bougie, jet ventilator, so many things. I'm not going to really bore you with all these things. What we're going to try to do is I'm going to try to explain to you how you can use your usual things in your setup and try to improve or prevent complications in your setup. This is what I'll try to do for you. All right. So let's see a typical day. All right, a typical day. You're post call and about to run home. You have not brushed your teeth, and you want to get back to home as quickly as possible. You're feeling hungry, as now also you're feeling hungry, no doubt about it. And a gentleman, 72 years old, comes into the ICU or comes into the ER for that matter, and he's breathing heavily. So he has a saturation of less than 86%. And he's at a respirator of 40. It's 9 a.m. in the morning. We're shifting at around 9:30. So at 9 a.m. he comes into the ICU, into the hospital for that matter, with a saturation of less than 86 and a respirator of 40. So I am the person standing on the desk. I'm the nurse, and I'm basically called up the page the doctor come in, and we have Dr. Paulomi and Dr. Vaijanti who come in to take care of this patient. So let's see our typical day. Dr. Paulomi, this is your patient.
Hello, sir. Since when you are having this complaint? He's breathing very heavily. His saturations. We started nasal cannula. We started 2 liters. We cannot go more than 6 liters as it will cause nasal mucosal drying and it will cause irritability. So we just give nasal cannula, see for his vitals in the meantime if it picks up.
Alright, so they do apply a nasal cannula. So they have now applied a nasal cannula, and we see the saturation is reached around 88, but it's still less than 88 and is still breathing fast. He's breathing at a respirator of 38. Alright, he's at a respirator of 38. So definitely she's added a nasal cannula. but doesn't look like it's done anything to this patient. He's still sick. We can see that he's still sick. All right, so let me get back to what's going to do further.
I don't think so. Nasal cannula is working for him. We can apply face mask and see. I'll make the face mask at 6 liters of O2, and it will be. I'll apply it properly. It covers the nasal and oral space.
Make sure there's no leak.
Yeah. And give 6 liters of water. It will be more comfortable for patient compared to nasal cannula.
Let's see whether he's doing better with this.
All right, so both the doctors have been trying their level best to get that oxygen up, and so they've applied a face mask, and the face mask, the saturation is still around 88 and not really gone up, and the patient's respiratory rate is 38. Now, they've lost 4 good minutes on trying to improve this patient as of now, and doctor, what are you doing? Can you do something further?
I don't think he's doing too good.
And we are losing our 4 precious minutes.
Can we do that one?
I think so. We can try with the NRVM. Let's get NRVM and see
Just
if
try
it
it.
helps.
But yeah, we'll see.
Enacting of the NRVM. So we'll give the oxygen up to 15 liters. We'll see the reservoir bag. It has to be completely filled up. And that's our hope. Let's see. We are losing our precious time here.
I don't think we should wait for a long time, but just wait and we'll just
Yeah,
decide in
this is
some time what
whatever
can be done.
vitals we see.
All right, all right. So they have gone from starting with a nasal cannula, and they've reached to a mask, and with the mask, the saturation still was less than 88, and then they decided to go to a non-rebreathing mask. Now, what is a non-rebreathing mask? It basically has two valves on the top and one valve down here. So whatever oxygen comes in first gets accumulated into the big bag down there, and that 100% oxygen gets inside because the respiratory flaps that if you breathe out, it will get the oxygen, all the air outside, whereas the air that comes in from the bag will fill up the chamber and make it 100% oxygen. So yes, so Dr. Paulomi decided to put an NRVM, and both the doctors hoped that the patient's saturation would possibly come up. So let's see what really occurred. So now the frustration levels are creeping up. The patient is on an NRVM. The saturation is still less than 90, and now his respirator has gone somewhere close to 50. So there we have a problem. We have a patient who's come in with nasal cannula. They were actually just sitting and they thought that maybe we just put a nasal cannula and they'll be fine. They started a mask. The mask saturation didn't pick up. Then they went on to an NRVM. It still hasn't picked up. This still hasn't picked up. Now, what do you do next, Dr. Paulomi?
I think we should help him with an NIV. We should give it a trial of an IV. What do you think?
We'll intubate this patient because I don't think so we have time. We are losing almost 6 minutes out here.
Okay, that's
So I think so we just get our trolley and we start with the intubation for this patient. We can't afford to lose him.
we need to give him medications first.
Yeah, please give him the medication. Give him propofol and scolded. Give it. We can't waste time. We have to intubate this patient.
All right. So she went from a situation of a saturation less than 86 to from a nasal cannula to a mask to an NRVM, and now she's on a frustration situation where she's just intubated this patient. What have we missed out of here? Can anyone tell me what have we missed out of here? In this last, what did we forget? Before the NIV, is there something that you'd like to say about what they've missed out of here?
Vital.
No, what have we done? This is just an emergency management. We are not looking at clinical scenario at all. Sorry? I'm just the maintenance. What are we looking at? We're looking at a pre-oxygenation, right? Isn't it? Have they done pre-oxygenation here?
Yeah, we did. We applied for nasal cannula. We went for the face mask. We did NRVM. We have given sufficient oxygen to patient, but it just didn't pick up.
So that's what the doctor says. I mean, they've done pre-oxygenation, isn't it? They've used the nasal cannula, they've used the mask, and they've used the NRVM. Isn't that pre-oxygenation? Yes or not? Why not?
Preoxygenation is actually with a full oxygen with a bag.
So they have the NRVM there, which is full oxygen.
That must be.
So let's come to the answer. The answer is not, was pre-oxygenation, no doubt, but this probably was not adequate pre-oxygenation. We put it this way. It's possibly not adequate pre-oxygenation. You got the point? It's not adequate pre-oxygenation. So why do we pre-oxygenate? Okay, so let's understand why do we pre-oxygenate. It's like bungee jumping. When you're intubating a patient, it's like bungee jumping. You're safe because you're tied to the leg. Okay, you're safe because you're tied to the. If you didn't have that tight, you'll be possibly dead, isn't it? Similarly, there is a certain time that we require so that we can do our airway manipulations, and that time is called as the apnea time. That time is called as the apnea time. It is this apnea time that prevents us for our patients, to prevent them from desaturating. This is called as the apnea time. And that's what we're trying to do by doing pre-oxygenation. We're trying to increase the apnea time of our patients, so that we have adequate time for our airway manipulations. See, when she was actually trying to intubate the patient, there was no airway, nothing at all. She's absolutely nothing. So at that stage, if she had some more time, maybe she would have gotten the airway easier. The patient wouldn't have really succumbed to what was happening, isn't it? And why is that so? Because if you look at the oxygen hemoglobin dissociation curve, it has got saturation on its y-axis and PaO2 on its x-axis. And this curve is the basis behind oxygenation. You must understand that at 90, your saturation is quite up. At 90 saturation, it does look like it is on the flat part of the oxygen hemoglobin dissociation curve. Beyond 90, before it even reaches it takes hardly minutes before it can go down to saturation to PaO2s of 20 and 40. You understand? So if you start at say 600 PaO2, your saturation is 100. You go to 500, it is 100. You go to 80, it is 100. It goes to 60, it is still around 90. But the moment the saturation goes less than 90, that means it's going to be on the steeper part of the curve, and this patient is going to desaturate much, much, much faster. So it's going to be 5 minutes from 100%, maybe 5 minutes from 100% to 90%, and it's going to be seconds from 90 to say 50. You got the point what I'm telling you, what I'm trying to get to you. Okay, that is the time that we want to increase in our patients. Okay, so let's look at what standard anesthesia is all about. What is standard anesthesia? Alright, standard anesthesia. Many of you all may be anesthetists, maybe it may not be something new to you, but there are a few people in the audience who will possibly want to know what standard anesthesia is all about, and how do we look at standard anesthesia. So Dr. Polomi is the anesthetist, and Dr. Vajanti is going to be the person who's going to help her out. Yeah, let's see standard anesthesia.
So this is our patient posted for the OT. We'll be inducing this patient. So Dr. Vajanti, if you can please give 100 milligram of propofol, fentanyl of 100 micrograms, and give midazolam of 2 mg. I'll check for the eyelash reflex, whether the sedation is working or not. Eyelash reflex is absent. Sedation has worked quite well. And just oxygenate this patient. Please give the paralyzing agent, give scoline of 50 mg. I see no respiratory efforts. We'll start with the. We are achieving good chest rise, and then we should intubate this patient now.
Right. So that's what they did, isn't it? So what is standard anesthesia? You first use an induction agent, alright, something like propofols, midazolam, something like that. And then the next thing that they do is they backmask the patient for some time. They do backmasking for some time. Then they paralyze the patient. After they paralyze the patient, then they again backmask for some time. Okay, and then you intubate the patient. So this is standard anesthesia. Standard anesthesia. Now let's take another patient who's basically having, say, a bowel pathology and has come for an intestinal obstruction. Alright, we're going to take something like that. And we have something called as rapid sequence induction. You've heard about rapid sequence induction? It's something that you do fast. Okay, that's what rapid sequence induction is all about. So let's see, Dr. Pallavi, what is rapid sequence induction?
So this is our second patient's come with a bowel obstruction. We are going ahead with the rapid sequence intubation for this patient. Dr. Vajanti, please give him 100 milligram of propofol, 100 micrograms of Fenta, and give scoline. And intubate this patient.
So what's not there in this? Absolutely. So what's happening in this kind of situation? The diagnosis is out. So you have induction, you have paralytic agent, and you have intubation. That's what is rapid sequence induction for such cases of bowel pathology or maybe obesity. All right. But this will give you around 45 to 60 seconds before which the patient desaturates. Only 45 to 60 seconds. So you need to do all these things within 45 to 60 seconds, because after that the patient will desaturate and down. That's what's going to occur. All right. So what did they decide to do? Way long back. What they decided to do was this study came out in something 1960s, where they actually started now giving oxygen during rapid sequence induction. Till now we didn't think about oxygen rapid sequence induction. They started giving oxygen. So when they started giving oxygen for rapid sequence induction, what they did find out that if you give 100% oxygen, you have around 5 minutes before the patient desaturates. Mind you, before that, when we talked about rapid sequence induction, it was taking only 45 to 60 seconds for the patient to actually start desaturating. Here you have an apnea time after giving 100% oxygen to close to around 5 minutes after giving 100% oxygen. Clear on this till now? So why do we want to pre-oxygenate our patients? There are 3 reasons for it. One reason being to get to 100%. The other one being to fill the store full, to fill the functional residual capacity full of oxygen. And the third being to oxygenate the blood. There are only 3 reasons why you want to pre-oxygenate, and these 3 reasons together helps us to prolong the apnea time in our patients. This is what really occurs. Alright, so let's look at the typical day again. We have the same patient that comes in. Alright, this was our patient. Our patient was a patient whose respirator was 40 and a saturation of less than 90, isn't it? That means he had a lack of oxygen. That was very evident because the saturation was low, he was breathing fast, there was a lack of oxygen. And there's a whole lot of reasons which will be responsible for the lack of oxygen. It could be anywhere from inadequate alveolar oxygenation to low VQ mismatch to diffusion abnormalities to dead space, and the most important, low venous blood saturation and the shunt. Alright, so the rest of these things, inadequate alveolar oxygenation, low VQ mismatch, diffusion abnormalities and dead space, will improve with even 2 or 3 liters of oxygen. Even if you give 2 or 3 liters of oxygen, these patients will kind of improve. But it is these 2 cases, low venous blood saturation and shunt, which are our patients that come for critically, which are those patients who are critically ill, who do not respond to that 2-3 liters of oxygen. Alright, so let's look at what a shunt is. What is a shunt? Alright, so let's take a normal alveoli. The middle one is the normal alveoli, and that's the vessel beside the alveolar, the capillary under the alveoli. So you have oxygen coming in through. When oxygen comes in through, your saturation on the venous side is 70%. It gets oxygenated, and at the arterial side it becomes 100%. Clear on this? This is what normally occurs. Can I just repeat this once more for you guys? Alright, so you have a patient who's in front of you, you give oxygen. Normally, he's not a normal patient. You give oxygen, give it to me, this is also going to occur to me. My saturation on the venous end is 70. I give oxygen, the 70 becomes 100 once the capillaries, the blood flows through besides the alveoli. This is what normally occurs. Alright, now let's do one thing. Let's put this patient full of fluid or pus or atelectasis. This is our usual patient, isn't it? This is our usual patient. And what happens when you put fluid, pus or atelectasis? The oxygen does come down, but doesn't go beyond that. So our saturation that was 70 goes ahead, and at the end of the day we get again 70. So the oxygenation per se that we were doing, which we thought will possibly improve our patients, does not cause any change in the saturation is what it looks like. Am I getting the point through? And this is what is called as a shunt. And this is what we see in many of our patients who come into the ICU or into the emergency rooms. So we give oxygen, they don't improve. We give oxygen, they don't improve. That's what our typical patient did. Okay, this is our patient. That's a shunt physiology. Fluid, pus and atelectasis. So when I started, I also talked about something called as low venous blood saturation. Now what is this? This is another thing that doesn't improve with the usual oxygen measures. So what is this? So you have an arterial end saturation and you have a venous end saturation. Right? So normally what happens? The blood flows through from arterial end to venous end and oxygen is extracted. This is what normally occurs. And then the venous end saturation is what we get, around 70% is what we're looking at when this occurs. Clear on this? Now what happens in a case of critically ill patient? That oxygen extraction is just too high. It is just too high. That's what occurs in shock. That's what occurs in shock. The oxygen extraction is so high that the venous end saturation is very, very low. You understand? That's why your venous end saturation is so low that your oxygenation might not get it to that level that you wanted it to come to. So let us see our patient now. So you have the oxygen coming through. I repeat again. The RBC going through. The 70 becomes 100. Alright. Now oxygen going through. 50 is your venous saturation because it was low. Initially we started at 70 if you remember. Now the venous saturation is 50. It's low venous saturation. You understood what low venous saturation is all about. So it is 50 and then oxygenation gets through and that's what, it remains at 50. This is what really occurs and this is what is low venous oxygen saturation. It doesn't go up much. Clear on this till now? Clear on this? It doesn't go up. It may go from 50 to 70 to 80 but it won't go to 100. You know, the earlier case 70 became 100. Here the 50 becomes around 80. So it doesn't really go up. You got the point? So our typical day patient that we talked about is this patient of ours. This is our patient. The patient who is shunted, who has low venous oxygen saturation and most probably because he's in shock, in septic shock. So what happens to them? He has a low venous saturation, he's got fluid, he's got pus, he's got atelectasis, right? And so whatever oxygen comes in, nothing occurs and he remains from 50 to 50. Nothing at all occurs. So he started at a low saturation and he remains at a low saturation. This is our patient that is coming to us. This is our patient. Clear on this? Alright. So now let's go ahead. What's happening to her now? Let her get back to this. Now she's trying to intubate. She's come to a condition where she's trying to intubate. Huh?
Saturation. Is the saturation
Stopping. Come fast. Come on, can you see?
No, it's very difficult.
Isn't this the usual case? That's it, follow me. Alright, so you start the NRVM. This is what you do. Then you take up the NRVM, you start ventilating, and the person who's using the NRVM generally is stressed up, is frustrated, is a relative junior person that is possibly. All of us are juniors, right? And it's very difficult to actually use the NRVM at this stage. You go to a saturation of 0.9 FiO2, but still you are not able to ventilate our patient. So what really occurs? Oh my freaking God, there's multiple attempts going on. The patient's, the bag mask ventilations, respiratory rate is equal to the doctor's pulse rate. And the insufflation pressure of that ambu bag is equal to the doctor's ICP. And what happens to this? The patient then aspirates. The patient aspirates and that, oh my freaking God, is not the way it is. He becomes, I am going to God. Okay? And that's the end of the patient. The patient is with God now. So this is what really occurs. Okay? Clear on this? So this is our typical day that really occurs. So that's what we are trying to do is we are trying to increase this apnea time. We want to increase this apnea time. So if you want to increase that, so let's recap it. It takes 23 seconds for a critically ill patient to desaturate. Hardly 23 seconds. Hardly 23 seconds. So what is the high FiO2 source that we'd like to give? So we possibly want to give the highest FiO2 source. And for that you have the NRVM. Yes, no doubt about it. The NRVM is a high FiO2 source. The preoxygenation is for, you have to do it for at least 3-minute tidal volume breaths or 8 vital capacity breaths. If this patient can do this, he will not be critically ill. If this patient can do 3 minutes of tidal volume ventilation or nice 8 vital capacity breaths, he cannot be in ICU. He's a normal patient. Only normal patients can do that. Okay, critically ill patients can't do that. Right? So, what if the SpO2 does not rise? That's where you change everything and NIV comes in place. NIV has positive pressure. Till now we didn't have positive pressure. Now comes positive pressure. Ambu bag doesn't give positive pressure unless there's a PEEP valve. Alright. So now you have NIV coming in and with CPAP we do know that there is no gastric distension in such cases, no cardiovascular effects if you use it at the usual pressures. And in what position you like to do it? You like to do it in the propped up position. You have to pre-oxygenate this patient in the propped up position primarily because supine sucks, not because it just sucks. It's because 386 versus 283 is the tidal volume. That time it takes for it to desaturate if you were supine versus propped up. Alright, so the head high is actually good during pre-oxygenation. So in our case, what we'd like to do is once you come to nasal cannula, you'd like to go to CPAP. CPAP with an FiO2 of 100% and it will possibly make a lot of sense to apply the nasal cannula and crank it to the maximum so that the nasal cannula plus the pressure together will work as high flow nasal cannula plus the NIV together, which will thus get the pressures up and thus make the source as much as possible high. So this 8 long minutes will be much longer than you think of if you were to do this kind of a maneuver. So can apneic oxygen increase apnea time? Yes. How does it increase that? If the patient is paralyzed, it will still cause the oxygenation to increase. How does that occur? So this is the oxygens, the red is the oxygen, the blue is the carbon dioxide. When you're in apnea, the oxygen diffuses quite quickly inside. The oxygen diffuses quite quickly inside. It is very low amount of carbon dioxide that comes outside. So what really occurs, there's a negative pressure gradient that is formed. And that negative pressure gradient, even without you actually ventilating your patient, causes that oxygen to move into the vessel. So this is called as apneic oxygenation. Okay, so you don't really need to do manual ventilation because the rate of rise of carbon dioxide is barely 3 millimeters of mercury per minute. So you're not really worried of the carbon dioxide, worried of the oxygen. Right? So what position of apneic oxygen? We say propped up position. That's choice of paradigm agent. That's a different situation. So the take home message for this is we have a pre-oxygenation period. You possibly want to use the position to be right. You possibly use a combination of CPAP plus nasal cannula. Okay, you do it for a sufficient period of time, at least 2 or 3 minutes. Then you give a jaw thrust because you want to keep this open. Only if you keep it open will your apneic oxygenation work. If there is something inside, apneic oxygenation is not going to work. So there has to be an open track, maybe the nasal cannula and oral airway, and then you go for an intubation period. So see to it that you don't remove this nasal cannula during the intubation period. If you have a nasal cannula in place, it will keep on doing apneic oxygenation. So when you are intubating and the nasal cannula is in place, apneic oxygenation will continue, and that's how these patients will kind of improve. Thank you very much. Yeah. So I think you all can please go for lunch, and we'll have the other batch coming in. They're there? Yeah, yeah. And please follow your own group, all right? Follow your own group.
As we do, okay, we'll be natural. So naturally,
You have column? Column? I think she has the audio better. I'm standing here and talking most of the time.
That mic also catching. It's clear.
So this one group has come. You all finished your lunch now? Food was okay?
Very nice.
Good. So you been enjoying the day till now?
Yeah.
Huh? Where are you all from?